Our next section is cardiomyopathy and pericardial disease. Dilated cardiomyopathy is very similar to the systolic dysfunction congestive failure in the previous section, so this will be easy. Hypertrophic cardiomyopathy from hypertension, restrictive cardiomyopathy, and acute pericarditis. All the things that cause acute pericarditis can also cause tamponade if they make fluid, and if they're chronic and cause fibrosis, they become constrictive. A cardiomyopathy literally means the abnormal function of heart muscle. It means that the heart is not contracting in a normal fashion. And although there are frequently valve and auscultatory abnormalities, the major origin of the problem is that the muscle itself is diseased. So it's a muscle problem leading to a valve problem, not the valve problem leading to a muscle problem. Cardiomyopathies can be dilated, hypertrophic, restrictive. The term dilated cardiomyopathy, systolic dysfunction, low ejection fraction are often used interchangeably. Hypertrophic cardiomyopathy is interchangeable with diastolic dysfunction or cardiac failure with a preserved ejection fraction. This is why all forms of cardiomyopathy lead to shortness of breath, particularly worsened by exertion. They can all cause backflow of blood, leading to edema from increased hydrostatic pressure in the blood vessels. They all cause congestion in the lungs, leading to ralls on exam, sometimes called crepitations, worse in the bases than in the apex, and all lead to jugular venous distension in severe and especially in decompensated cases. All forms of cardiomyopathy are best initially diagnosed with an echocardiogram. The most accurate test is often only the echocardiogram, although the catheterization may provide some more information on pressures. Echocardiogram for a simple cardiomyopathy is the only test that we really use. And that is why it's often also the most accurate test that we use. And EKG and chest x-ray, although they should be performed, there's really nothing specific on them that confirms a diagnosis. You can't really look at a EKG and go, that EKG definitely shows cardiomyopathy. Impossible. There's nothing on an EKG that can tell you that that EKG shows cardiomyopathy. There's things on the EKG that can show, well, you had an old infarction or you have hypertrophy, but you can't tell symptoms from it. You can't tell wall motion from it. You can't tell wall motion from an x-ray. It might be dilated, but you can't tell how it moves. You're going to look for murmurs that are not increasing with expiration, such as HOCM or mitral valve prolapse as well. The best initial therapy for all forms of cardiomyopathy is a diuretic. That's because we're not talking about hypertrophic obstructive cardiomyopathy. That hypertrophic obstructive cardiomyopathy doesn't get treated with the diuretic because hypertrophic obstructive cardiomyopathy, the obstruction increases. The other treatments and what else you'll do and what it says as the next best step after the diuretic is based on, well, which type of cardiomyopathy is it? Fundamentally, in terms of different answers, the only difference is the management question, the answer to the question on treatment. That's it. Shortness of breath is the same on all of them. EKG and chest x-ray are non-specific on all of them. Echocardiogram is the most accurate on all of them. So what's different? Treatment. Now to go one step further, in addition to myocardial infarction and ischemia, because MI and ischemia make everything dilate. Infarction leads to dilation. But in addition to infarction and ischemia, which make it dilate, because dead things dilate and don't move, dilated cardiomyopathy is also from alcohol, because the direct poison, the alcohol poisons and pickles that heart, just doesn't move. And many of them are viral myocarditises that were never really diagnosed. We presume that they're viral myocarditis. Radiation can do it, although it's rare. toxins are obvious from the history. Nobody suddenly shows up with doxorubicin or adriamycin-induced cardiomyopathy. They know it. They took doxorubicin and adriamycin. They had chemotherapy. They had lymphoma. They got their chest radiated. It's not like it's a surprise. You could see it in the history. It has to be in the history. If someone goes home and takes doxorubicin and they didn't tell you, you would never be able to figure it out. You can't do a blood adriamycin level. It's in the history. It's in the history. Chagas disease does it because that infection infects the heart valve. It's very rare in the United States. And once again, they'd have to tell you. They'd have to tell you that the person traveled. They'd have to tell you they went to Brazil. It would have to be in the history. The presentation of physical finding, shortness of breath, and S3 gallop, edema, the tests are all the same as what we did in the CHF section. The only good thing about having dilated cardiomyopathy, as opposed to the other forms of cardiomyopathy, is that you have multiple medications that can decrease mortality. No, it's not good to have a disease, but it's good to have a disease you can do something about. Vasodilators are good. ACE inhibitors are vasodilators that are even gooder because they decrease the pressure work of the heart. Now, what's more costly to the heart for myocardial oxygen consumption? Is it pressure or is it volume? Well, pressure work is more costly. That's why these drugs really lower mortality, because they decrease the pressure work and the myocardial oxygen consumption. Now, both of them are class effects. That means whether it's captopril, and enalapril, ramipril, fascinolopril, amipril, they're all okay. And in terms of ARBs, valsartan, losartan, irbesartan, candesartan, telmisartan, anisartan, all okay. Beta blockers is different. Atenolol is not good. Atenolol. Metoprolol, carvedilol, bisoprolol are the beta blockers proven to lower mortality in dilated cardiomyopathy. And this question will be very specific for you. It'll say a person's on an ACE or an ARB and on a beta blocker and say which of the following is most likely to benefit this patient. The right answer will be spironolactone or eplerenone. The wrong answers will be diuretics and digoxin. Diuretics and digoxin are good because they control symptoms and make you less short of breath. Digoxin decreases the frequency of hospitalization. Digoxin decreases the frequency of hospitalization. But that's different than saying it adds years to your life. The most common source of confusion is using spironolactone because we think it's in a diuretic dose. We're not giving it as a diuretic. We're giving it to be an aft-load reducer and to decrease the renin-angiotensin-aldosterone system. A patient is on an ACE inhibitor or an ARB, a beta blocker, and spironolactone. They have the use of diuretics and digoxin, and they're still symptomatic. They're still short of breath. What is the next best step in the management of this patient? Because if you have all of those therapies and you're still short of breath, well, we want to try and keep you off of the cardiac transplant list. What else can you do? The wrong answer is warfarin. The wrong answer is combining ACE and ARBs. Combo ACE and ARBs is no good. If there's a wide QRS, the answer is a biventricular pacemaker, both ventricles at the same time. They increase survival, decrease symptoms, and you can also use the implantable defibrillator because the biventricular pacemaker also has implantable defibrillator function, which definitely lowers mortality. The biventricular pacer decreases symptoms. People get off that table and they walk home. It's amazing what the synchronization will do. And the implantable defibrillator keeps you alive. MCC means most common cause. The most common cause of hypertrophic cardiomyopathy is high blood pressure. Now, you have to distinguish for sure between HOCM and HCM. Hypertrophic obstructive cardiomyopathy is colossally different. Hypertrophic obstructive cardiomyopathy causes syncope and sudden death. Hypertrophic cardiomyopathy is just a reaction to high blood pressure. The heart hypertrophies carry the load, law of Laplace. The thicker the wall thickness, the less the load. The thicker the wall thickness, the less the load. And the problem is that this is a person who has difficulty relaxing in their heart. And they can't relax, they can't receive blood. They can't receive blood, they can't pump blood forward, and the patient becomes short of breath. Hypertrophic obstructive cardiomyopathy, genetic disorder, familial disorder, it just happens. It's an abnormal shape of that septum. The septum bumps up against the other parts of the heart because it's asymmetrically hypertrophied. That's one of the names of it, asymmetric septal hypertrophy. And you can see the arrow is showing you an obstructed left ventricular outflow tract. That's why anything that makes the heart smaller increases the obstruction. Anything that causes a tachycardia will make the heart smaller. That's why when you exercise, dehydrated, diuretic, exercise, dehydrated, diuretic. Anything that empties the heart, like digoxin or ACE inhibitors, increase the obstruction. All forms of hypertrophic cardiomyopathy can have an S4 gallop. S4 gallop is atrial systole against a stiff, non-compliant ventricle. Boom! It hits with a boom! It hits with a boom! It hits with a boom! 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 Instead of a nice relaxation. Now, there's less signs of right heart failure in hypertrophic cardiomyopathy, less ascites, and less enlargement of liver and spleen, because you see, hypertrophic cardiomyopathy is really hypertrophic cardiomyopathy of the left side of the heart, not the right. That's why there's less ascites and less enlargement of the liver and the spleen. Because ascites, liver, and spleen are signs of right heart failure. Hypertrophic obstructive cardiomyopathy. The most common presentation is still shortness of breath. It is. The most common presentation is not sudden death. You can get some chest pain. You have syncope, lightheadedness. But sudden death, particularly in athletes, is a very unusual finding. It's the most common wrong answer. Which of the following is the most common presentation? It's not sudden death, but it does occur. It's worsened by an increased heart rate, because anything that increases the heart rate, such as dehydration, exercise, diuretics, all these things that can make the heart chamber smaller, that increases the obstruction. Because it empties the heart. That's why ACE inhibitors and ARBs, hydrolysine, Valsalva, standing, empty heart. Whether it's decreased filling with Valsalva and standing, decreased filling or increased emptying, the heart is emptier and there's more obstruction. As it is in all valvular and all cardiomyopathy diseases, the best initial test is an echocardiogram. Again, follow the same pattern of transthoracic echo. First, transesophageal echo is more accurate. The septum should be unusually thick, more than 1.5 times the thickness of the posterior wall. And systolic anterior motion of the mitral valve, basically the mitral valve with the obstruction sort of gets sucked into the wrong direction. It gets sucked anteriorly and helps contribute to the obstruction. And catheterization may be the most accurate test, but it's again really necessary for a specific diagnosis. The EKG is going to show left ventricular hypertrophy, and although it could even be normal, if you have an abnormal echo and a normal EKG, go with the echo. Always go with the echo. Septal Q waves are not here a sign of infarction. They're not. Q waves, everything else would be a sign of infarction. But in HOCM, they're not a sign of infarction. They're simply a sign of an abnormal septal thickening. The best initial therapy for patients with hypertrophic cardiomyopathy and hypertrophic obstructive cardiomyopathy is a beta blocker. Now, for the first 40 years they were used, we thought the most important feature was that they were negative inotropes. Well, it turns out that the most important feature is that they slow the heart rate. When you slow the heart rate, you allow an increased diastolic filling time. So if you go from a heart rate of 90 to a heart rate of 60, you have given a 50% increase in diastolic filling time. That's really useful because they really help. Now, diuretics help hypertrophic cardiomyopathy because it's a fluid overload state, but diuretics harm HOCM because they increase the obstruction. Spironolactone, digoxin are basically not helpful in hypertrophic cardiomyopathy. That's one of the reasons you have to do an echocardiogram in everyone who's got congestive failure, because you just can't tell who's got which type of cardiomyopathy. The implantable defibrillator is for people who have the HOCM, the obstructive cardiomyopathy, and develop syncope. Beta blockers, syncope gets the implantable defibrillator. Well, what would you do next if they continue to have symptoms? Then the next best step in the therapy is ablation. Cut it out. Ooh, cutting it out is very difficult. Let's try a catheter in there first. Catheter to ablate the septum. The catheter. Put absolute alcohol in the septum. Put little micro infarctions. Basically just kill off little parts of it. Just kill off little parts of it so it gets smaller. And then if the symptoms persist, you'll do a surgical myomectomy. But surgical myomectomy is definitely only when the other procedures fail. Now, you don't have to be a mind reader on step 2. They have to tell you. They have to tell you they got symptoms despite beta blockers and despite the implantable defibrillator that had syncope and despite the ablation with the alcohol. They continue to have shortness of breath and lightheadedness. Surgical myomectomy. Because you can't do ACE inhibitors or diuretics. You can't use in HOCM, ACE, ARB, hydralazine, diuretics, digoxin, all of them are going to hurt the patient because all of them empty the heart, and an empty heart is worse than HOCM. Let's summarize the therapy between hypertrophic and dilated cardiomyopathy. Well, they both get beta blockers. Well, they both get diuretics. And remember, we mean hypertrophic cardiomyopathy, not labeling it hypertrophic obstructive. And in terms of ACE inhibitors, they unclear benefit in hypertrophic cardiomyopathy. Unclear benefit in hypertrophic cardiomyopathy. Definitely beneficial in dilated. The biggest clear differences is that spironolactone doesn't help hypertrophic cardiomyopathy, but spironolactone definitely helps dilated cardiomyopathy, and digoxin doesn't help hypertrophic cardiomyopathy, and digoxin may not lower mortality in dilated, but it certainly decreases symptoms, so it helps. Wow, at least I'm glad I don't have a restrictive cardiomyopathy because it's got the worst aspects of dilated and hypertrophic. A dilated cardiomyopathy may not be able to contract, but at least dilated can relax, but restrictive can't. Hypertrophic cardiomyopathy may not be able to relax, but at least it can contract. But restrictive doesn't. Restrictive cardiomyopathy neither contracts nor relaxes. It's just immobile because of infiltrating substances, making it just freeze. Which of the following is the most likely diagnosis? Let's look for some things in the history. Do you have a history of sarcoid, amyloid, hemochromatosis, cancer, and fibrosis, scleroderma fibrosis? Well, these are all things: sarcoid, amyloid, hemochromatosis, cancer, and fibrosis that simply make it that the heart does not move. The heart does not move. You treat the underlying cause. And if, something like endomyocardial fibrosis, you really can't treat the underlying cause, well, then you really can't treat the restrictive cardiomyopathy. And all you can give is diuretics for symptomatic control. That's not very satisfying, but it is the answer. It would be very hard for you to detect restrictive cardiomyopathy simply from a presentation. And that's because fundamentally the presentation of shortness of breath, right heart failure, ascites, edema, and JVD, a big liver and a big spleen, is simply not enough to be able to say it's restrictive cardiomyopathy. Now, the right heart failure, where the right heart doesn't fill with ascites and edema and JVD, is certainly more unique to restrictive cardiomyopathy, but by itself it's not enough, not even the presence of pulmonary hypertension. Now, the single most specific physical finding is Kussmaul's sign. Kussmaul is increase in jugular venous pressure on inhalation. That's certainly the most unique of the physical findings. It's in constrictive pericarditis as well, but in terms of cardiomyopathy, it's the most unique finding for the restrictive cardiomyopathy. The best initial test is the echocardiogram. The ejection fraction will be normal sometimes. Occasionally it's elevated. The EKG shows nothing specific. Low voltage, low voltage. Obese people can have low voltage, and barrel chest and fat people and people with large breasts can have low voltage, and pericardial tamponade and effusion can have low voltage. It just means that the impulses are not able to transmit through too much, but that's pretty nonspecific. Amyloidosis does have a very specific echo finding, and this is important. Amyloid will find on the echocardiogram. On the echo, you will see speckling pattern, speckling, like glass, like light going through crystal, speckled. The most accurate test is frankly rarely if ever done, and that's an endomyocardial biopsy. It's rarely if ever done, but it is the most accurate. Rarely done, but it is the most accurate because you can make your diagnosis by taking samples elsewhere, other tests. The best initial therapy, treat the underlying cause. Diuretics will help decrease the fluid overload, decrease some pulmonary hypertension, decrease the ascites and the edema, but there's no other clear therapy. You gotta give steroids for the sarcoid, and you gotta do phlebotomy for the hemochromatosis, and you gotta give a person with eosinophils some steroids too, but there's no other really specific therapy just to say restrictive cardiomyopathy. I'm sure a number of you are very high-functioning people that got this on the first time. But in my experience, auscultatory maneuvers, let's repeat it. Let's make 100% sure. Squatting and leg raise. Squatting, you go from a standing position, squat, and squeeze your leg vein, squeeze your leg vein. Same as leg raising. More blood returns to the heart and will increase both mitral and aortic stenosis. Standing opens the venous capacitance vessels. Valsalva decreases venous return. Exhalation against the closed glottis and will decrease both of them. Less blood, less murmur. And these same findings will occur in regurgitant lesions. More blood, more murmur. Less blood, less murmur. Mitral valve prolapse is quite simply knowing it is the opposite, and so is HOCM. Less blood, less murmur. More blood, more murmur, except for mitral valve prolapse and hypertrophic obstructive cardiomyopathy, where a smaller, emptier heart makes more murmur. More blood increases the intensity of all those murmurs, but not mitral valve prolapse or HOCM. Less blood decreases all the murmurs except mitral valve prolapse and HOCM. And this is very simple why we're being repetitive on this. If you actually said, hey, Conrad Fisher, what is the most frequently asked auscultatory question on step 2CK? Conrad Fisher says the two things in front of you right now. When you stand from a squatting position, it opens the leg vessels. It simply makes it so the blood can't go up into the heart. You could pool a liter in each leg if you open up those leg veins. If you stand for half an hour without moving at all, you're going to be lightheaded. Valsalva does the same thing simply by increasing intrathoracic pressure and makes it so heart is just simply empty. And when you have decreased heart filling, you have less murmur, with the exception of those two lesions, mitral valve prolapse and HOCM, which increase. The auscultatory maneuvers, you see, they simulate the treatment. So if you have a lesion that gets better with diuretics, like aortic regurg, mitral regurg, aortic stenosis, mitral stenosis, if you have a lesion that gets better with the use of diuretics, then standing or Valsalva will make it better. Stenotic and regurgitant lesions all are treated with diuretics and salt restriction. That's why standing and Valsalva will improve them. That's why mitral valve prolapse and HOCM, which worsen with diuretics, because diuretics will make the left ventricular size smaller. That's why diuretics worsen mitral valve prolapse and worsen the obstruction of HOCM, and standing and Valsalva will worsen them. Hand grip, squeezing the muscles of the arm, squeezes the arteries of the arm, which increases afterload. The contraction of those arm muscles compressing those arteries will decrease emptying of the heart. It is the opposite of an ACE inhibitor. Since aortic regurg and mitral regurg get treated with an ACE inhibitor, hand grip will worsen them because it prevents blood from getting out of the heart. It pushes the blood backwards. It makes it worse. The maneuvers follow the treatment. The treatment follows the maneuvers. Amyl nitrate is rarely, if ever, done clinically. It acts as a direct-acting arterial or vasodilator, but the question that says, do you understand the auscultatory maneuvers with amyl nitrate is still important. It decreases afterload by being a vasodilator. It simulates ACE inhibitors or ARBs in the heart, and valvular lesions that get better with ACE or ARBs will get better with amyl nitrate, and therefore, since aortic regurgitation and mitral regurgitation get better with ACE inhibitors to increase the forward flow of the blood, amyl nitrate will improve them, and that is why amyl nitrate will worsen mitral valve prolapse and hypertrophic obstructive cardiomyopathy. We'll do the opposite. Hand grip is a fuller left ventricle. Amyl nitrate, like an ACE inhibitor, is an emptier left ventricle. That's why, in summarizing the effect of hand grip and amyl nitrate, we can see that these are clearly the opposite. We can see that mitral stenosis, the same way that there's no effect of hand grip, there'll be no effect of amyl nitrate. And there'll be no effect because mitral stenosis is not affected by ACE inhibitors or ARBs. Because ACE inhibitors and ARBs affect ventricular emptying. And mitral stenosis is a problem with ventricular filling. Aortic regurg is a problem with ventricular emptying. That's why hand grip will push it backwards and make it worse, and amyl nitrate will help it go forward because it's like an ACE inhibitor. And the same with mitral regurgitation. It follows it precisely. Now, if you weren't already clear, mitral valve prolapse does the opposite. HOCM does the opposite. Get it through the head. Hand grip and amyl nitrate have no effect on mitral stenosis in the same way that ACE inhibitors have no meaningful effect on mitral stenosis. For our next section, pericardial diseases. Now, pericarditis, pericardial tamponade, and constrictive pericarditis overlap because the etiology of them overlap. You see, if you have a cause of pericarditis that extravasates a ton of fluid, then you're going to get tamponade because that fluid can compress the heart. And if the pericarditis causes chronicity and time for it to fibrose and calcify, then that pericarditis can cause constrictive pericarditis by making it fibrose into constriction. That's why any infection, although virus is the most common as a cause of pericarditis, and any inflammatory disorder or connective tissue disorder, although lupus and uremia are the most common, and any chest wall trauma or cancer near the heart can cause pericarditis. Which of the following is the most common cause? And the answer is virus. Although lupus is the most common connective tissue disorder to cause pericarditis, any of them can do it. Wegener's granulomatosis is a vasculitis that can do it. Goodpasture syndrome causes inflammation of the lungs, and rheumatoid arthritis causes vasculitis, and polyarteritis nodosa, and Churg-Strauss syndrome, and microscopic polyangiitis, and any cause of vasculitis can inflame the heart, make it upset and angry with you, and cause pain, and cause pericarditis. The cool thing about pericarditis is that you have a very clear presentation of sharp chest pain that changes with respiration. That gets worse when you take a deep breath in, and changes with bodily position. It's better when I sit up and worse when I lie down. Better when I sit up and worse when I lie down, because when I sit up, I relieve stretch on the pericardium. When I lie back, I stretch the pericardium. And that's why answering the question, what is the most likely diagnosis, is much easier with pericarditis. The best initial test for pericarditis is an EKG. You see ST segment elevation everywhere, just about in almost every single lead. And PR segment depression is the single most specific finding. And look at the nice blue arrow showing that ST segment elevation everywhere. And look close for the PR depression, because that's going to really help you. And it is unique, the PR depression. Which of the following is the best initial therapy in the management of pericarditis? Number one, treat the cause. Except it's idiopathic most of the time, so you can't treat the cause. So we treat it symptomatically. Therefore, the best initial therapy of that Coxsackie B virus, which is idiopathic, is non-steroidal, such as ibuprofen or naproxen, which should make most people get better. Colchicine decreases recurrences. That's new. Colchicine is to decrease recurrences of pericarditis. The same way that any pneumonia can cause a pleural effusion, any cause of pericarditis can extravasate enough fluid to cause tamponade. Well, why do we say tamponade, not tamponade? Why do we drink lemonade and treat tamponade? And that's because lemonade is not a French word. See, tamponade means to compress something. And that's fluid compressing it, and the fluid starts to compress it on the right side, simply because the walls are thinner. That's why the right side, the right atrium, the right ventricle will collapse before the left atrium and the left ventricle. And if you get as little as 50 milliliters of fluid acutely, it can cause tamponade. But if it accumulates slowly, you can get liters of fluid in that pericardium, because it gives it time for it to stretch. But if it's from trauma, it doesn't have time to stretch, and you need to get that blood out of there in a big super emergency with a thoracotomy and a needle. The reason why this question, what's the most likely diagnosis, is so indispensably important in tamponade is that you often have to know it's there, so you can say, hey, I need my echo now. It's the middle of the night. Give me an echo this second. So you know you have to recognize it from hypotension, tachycardia, distended neck veins, hypotension, tachycardia, distended neck veins, clear lungs too, because congestive heart failure and pulmonary edema gives you hypotension, tachycardia, and distended neck veins. But pulmonary edema gives you pulmonary edema, and here the lungs are clear. And you may have to even put a needle in someone's chest for pericardiocentesis. But that question, which of the following is the most specific physical finding, is critically important. The most specific physical finding for that tamponade is the pulsus paradoxus. Pulsus paradoxus is defined as a decrease in blood pressure of greater than 10 millimeters of mercury upon inhalation. When you inhale, you increase venous return to the right side of the heart. In the normal person, the entire heart simply increases in external diameter, just gets bigger. But if your heart is compressed, and it's like living in a really small studio apartment in Queens, and 3 fat people move into your apartment, it displaces the left ventricle. That's what it's like in pulsus paradoxus. It's being compressed, and therefore it shoves over the left ventricle, and you get hypotensive. That's what pulsus paradoxus is. There's increased venous return at the expense of the left ventricle. It compresses, gets smaller, blood pressure drops. Pulsus paradoxus, very big deal, because it's the indication for the emergency pericardiocentesis. That is a truly, truly beautiful picture of a massive pericardial effusion. And I know that because it's my own resident and my own picture of my own patient in my own hospital. And that gray stuff is the pericardial fluid. You can even see the cool septum going diagonally across the middle of the heart. The heart is the part with the white stuff. The septum is the darker thing crossing in the middle. And the big black arrow points to the pericardial effusion. And that's a beautiful picture of pericardial effusion. You can't tell it's tamponading from a CT. You can tell it's tamponading from a pulsus paranoxus or from the echocardiogram, but not from the CT itself. The EKG most of the time in tamponade just shows tachycardia. But electrical alternans, sometimes hard to tell apart from the normal respiratory beat-to-beat variation. You see, when you have a heart that is swimming in that big puddle of fluid, and the heart flops backwards and forwards and backwards and forwards and backwards and forwards, when the heart moves forwards, the complexes get big. When the heart moves backwards, the complexes get small. And that's because where are the EKG leads? Are they in the anterior, the front of the chest, or the back? Well, they're in the front. I never saw an EKG put on someone's back. Even when they're lying on their stomach, I never saw it happen. So since the EKG leads are on the front, when the heart flops forward, it's closer to the EKG leads, and the complexes are bigger. When the heart moves back, it's further away. Complexes smaller. Electrical alternans is an essential feature of pericardial tamponade. The chest X-ray can find in a pericardial effusion that has been present for some time, a few days to a few weeks, an enlarged globular heart expanding in both directions. Emergency tamponade will not show this because you need time for the pericardium to stretch. The right atrium and the right ventricle will show diastolic collapse. As the heart is relaxing, the tamponade fluid will squish it. Right heart catheterization is the most accurate test with equalization of pressures. I didn't say I'd do it, but it is often the most accurate test, although we use the echo day to day most of the time. A 78-year-old man with lung cancer has several days of increasing shortness of breath. He's lightheaded, he's hypotensive a little bit, but he's tachycardic and his blood pressure drops. And you can see that there's clear lungs, tachycardia, hypotension, distended neck veins, and most importantly, it drops by 14 points of systolic pressure on inhalation. 14 points. What's the most appropriate to confirm this diagnosis? And the answer is most appropriate. Well, that's a tough question, isn't it, sometimes? What does it mean, appropriate? It means accurate enough, but not having to put a catheter in them. That's what it means. See, the echocardiogram will show right atrium, right ventricular diastolic collapse. The EKG is okay, but low voltage is pretty nonspecific, and electrical alternans, obviously, too rare. So what we want you to know is we want you to say, although the chest X-ray may show dilation in the globular heart later on, well, you can't count on that today. It needs time. It's still not as specific as seeing right atrium, right ventricular diastolic collapse. Catheterization may be good, but you know what? I need to know right now. And the other thing is, we just simply don't need to put needles into people's chests and catheter inside them when the echo simply can show it much easier. And cardiac MRI, honestly, is not right for anything at this time. Even if your attending said just today, oh, you always do a cardiac MRI, it's a US MLA, not a my attending who writes my evaluation MLA. Cardiac MRI is unclear at this time for when it is ever the right answer. The emergency treatment for tamponade is unquestionably that pericardiocentesis needle. The needle rapidly expands the heart, and that's because at 50 mLs acutely will compress that heart. Removing 50 mLs acutely will allow that heart to re-expand. IV fluids is incredibly important because the most common wrong answer is you see someone who's short of breath and you incorrectly say diuretics. Diuretics in a little bit of tamponade will kill the person because it will allow the right atrium, the right ventricle to collapse even more. Long-term therapy requires a hole, but that's not very precise. The window is a poetic way for saying a hole into the pericardium to prevent recurrences, to treat recurrent cases. And diuretics, I cannot overestimate how dangerous that is if you make that mistake. Diuretics will kill somebody. And let us point out at this time that if you think there's a difference between the questions you get wrong on your step 2 practice questions and the patients you might harm as a doctor next year, you're wrong. You're wrong. It's medicine. It's not just a bunch of questions. It matters. Constrictive pericarditis is a rare and unusual entity. If you're not around people who have tuberculosis, you may never see it. It prevents filling on the right side of the heart, and tuberculosis is frankly one of the only causes because viruses don't cause it because they're not chronic, and uremia doesn't do it because we have dialysis and we simply correct the cause. But tuberculosis, particularly in immigrants from endemic countries, is probably the single most common cause of a constrictive and fibrotic pericarditis, and you can see it definitely on the scan of the chest. What is the most likely diagnosis on constrictive? The heart can't fill. The heart can't fill. And I get edema because the heart can't fill. The heart can't fill and it backs up in myositis because the heart can't fill. The heart can't fill and it backs up in my liver and a big liver and a big spleen and a big hemorrhoids and jugular venous distension. And constrictive pericarditis gives several of these signs because the heart can't fill. Calcification on a chest x-ray and chest CT confirm the diagnosis. Which of the following physical findings is most likely to be found in this patient? And the answer is small sign. What happens to your neck veins when you inhale? What happens to a normal person when you inhale? Does your neck vein go up or down? And you can't feel them, so take your hand off your own neck. You see them. A normal person's neck vein should go down when you inhale. But in constrictive pericarditis, they go up. It's an increase in jugular venous distension on inhalation because normally those neck veins should go down. There's also pericardial knock, knock, knock. It can't fill. Filling, 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 filling. When it fills up to its maximum, it knocks. I know you couldn't hear what I was saying because of that knocking sound as your mind was filling up with knowledge. Oh, this is beautiful picture of calcification of constrictive pericarditis. Look at that white line. Look at that beautiful picture. And here it is on the lateral. And look at that beautiful picture of the constrictive pericarditis as the line of calcification goes around the heart. Isn't that wonderful? When I lean closer to the computer, I bet you can hear the knock right now just by looking at that picture. Constrictive pericarditis is an anatomic disease. It has an anatomic test, an x-ray, and a CT or an MRI. It has an anatomic treatment, which is to remove it. The echocardiogram is okay, but the myocardium moves normally, and it more or less excludes other diseases. It's not so much the echo diagnoses it as it excludes myocardial disease. Constrictive pericarditis is an anatomic disease. It has an anatomic presentation, big edema, big liver, big spleen. It has an anatomic test, x-ray, CT. It has an anatomic treatment, remove it. There's just no good medical therapy for constrictive pericarditis. Diuretics will decrease the fluid overload that's in people's edema and in their liver and their spleen and decompress the filling of the heart, but you can't diurese your way out of a constrictive pericarditis. You can't diurese your way out of calcification. Pericardial disease, viral pericarditis, is a functional disease, electrical function. You have a functional presentation, pain that's positional pleuritic and positional pleuritic. You have a functional unique finding called pericardial rub. You have a functional test for pericarditis called ST elevation, electrical function, PR depression. You have a functional treatment called anti-inflammatory function. Steroids if it doesn't work. Colchicine to prevent recurrences. It's a functional disease, electrical function. Tamponade is a hemodynamic disease. You have fluid extravasating from infection or cancer or inflammatory diseases, and you have a hemodynamic presentation with tachycardia, hypotension, extended neck veins, tachycardia, hypotension, extended neck veins. It has a hemodynamic test, the echocardiogram, looking for fluid pressing on the right side of the heart. Hemodynamic test most accurately with catheterization, equalization of pressures, even if it's rarely done. You have a hemodynamic therapy, which is pericardiocentesis. A hemodynamic therapy, put a window and drain it. And constrictive pericarditis is an anatomic disease. Big liver, big spleen, big organs, big ascites, an anatomic test, which is an X-ray, a CT, and MRI, an anatomic treatment, which is to surgically remove it. Pericarditis hasn't changed in 50 years. Learn it now, and you'll be good for the next 50.